The soundtrack is interesting. We don't usually have that at the medical meetings I'm at. So anyways, I'm so happy to be here. I'm just energized by all of you from all different places, walks of life, industry, government. I love this stuff. It's great. So I'm going to talk today a little bit about leading change and the high reliability journey. How many of you in this audience would say you're change agents? It's a little dark, I'm looking. I don't see 100% of hands up. So I hope by the end of this talk that every single person in this room is a change agent, because we need change. We need change. I'm going to talk about somebody that Ernest Amory Codman. Is this a household name? Yes? No? No. Okay. So he was a pioneering Boston surgeon, Harvard faculty, Mass General, all the fancy stuff. And he believed strongly in understanding what the patient was all about, what their condition, their demographics, all of those things, what the diagnosis and treatments were that they received in the hospital, and he believed in understanding the outcomes of the care that the patient received in the hospital, and even following the patient out as long as a year to understand what actually happened, what was the outcome of that surgery. That's what he stood for, and that's what he believed, understanding the care. And if it didn't go according to plan, if the outcome wasn't expected, to try to understand why and to prevent it from happening again. That's what he believed in the early 1900s. He also believed in publicly reporting errors and harm. Early 1900s. Public reporting. In fact, he wrote up his own error on a gallbladder surgery where he did something wrong. That's what he believed in. Wasn't very popular at the time. He called it his end results system. It was outrageous. I mean, his abrasive personality probably didn't help much either. But he was socially ostracized. He was asked to resign his privileges at Mass General. He was asked to resign as chair of the local medical society, and his referrals dwindled. But he was determined. He went on to form his own hospital. Forget MGH. I'm going to form my own hospital. So he called his hospital the End Results Hospital. Yeah. And he didn't stop there. He then went on with others to form and found the American College of Surgeons. And the American College of Surgeons is about making surgeons better, right? Helping, supporting, ensuring competency, right? And the American College of Surgeons also cared about the hospital that the surgeons were practicing in, and that they met certain standards of care. So the American College of Surgeons actually adopted Ernest Amory Codman's end result system and called it the Hospital Standardization Program. Yeah. So here you have the American College of Surgeons, and they have a hospital standardization program because they want to make sure that the hospitals are good and have the standards in place. Well, it turns out his practice really dwindled. He financially did not do so well in the end. And when he was dying, he told his wife, don't spend any money on a headstone because we don't have it. So he has been at a cemetery in the Boston area for many, many years with no headstone. And some people at the American College of Surgeons made it their mission to gather some funds from some stakeholders and put a proper headstone and pay tribute to this man, Ernest Amory Codman, just this past summer. Small dedication ceremony. And at the bottom of it is inscribed, "It may take 100 years for my ideas to be accepted." So here we are today in 2015, you know, with these ideas still not totally on board, people not totally aware, and we're still working on that. This is a snapshot of part of the minimum standards from 1917 that the American College of Surgeons developed and then started surveying hospitals on. And it's just 5 standards. I'm going to sum it up for you. Don't try to read it. It's, you know, have some competent, ethical surgeons that are licensed and physicians. Make sure they meet regularly and talk about the cases and understand what happened. Make sure you have lab and x-ray facilities that are competently supervised, and make sure there are complete and accurate medical records for every patient. That's it, the minimum standards. And only 12% of hospitals in those early 1900s actually met these standards. The American College of Surgeons eventually gave that program, transferred that program essentially to the Joint Commission, which was formed in 1951, and the standards were applied by the Joint Commission starting in 1953. In 1965, Medicare went into law, and actually the conditions of participation for Medicare were actually the Joint Commission standards. The conditions of participation were the Joint Commission standards. They underwent one rigorous update in 1987, and it's a continuous process at the Joint Commission to continue to update standards. And in the mid-1990s, there was a big incorporation of systems change, bringing in the work of Deming, Duran, and others around organizational leadership and data-driven process improvement. So why am I telling you all of this? This story about this man, standardization. Well, part of this is, what is the Joint Commission? Who are we, right? What is it that we do? We accredit organizations. They comply with standards that are the basis of quality and safety, the framework for quality and safety in organizations across the country. It's not about accreditation, it's about excellence in patient care. The Joint Commission accredits organizations and asks them to comply with the standards, but they actually voluntarily sign up to be accredited. They choose to be accredited by the Joint Commission to meet these standards. It's all about increasing standardization, and many would say, if you're increasing standardization, you're probably decreasing variation, right? Well, if you're decreasing variation, you're probably decreasing risk also. And if you're decreasing risk, you're probably improving quality and safety. Continuously improving quality and safety is what excellence in patient care is all about. That continuous drive to improve quality and safety. That's excellence in patient care. It doesn't stop. And that's the link between accreditation and excellence in patient care. It's all about standardization of key safety processes. I'm going to go over some of the top myths about the Joint Commission. The Joint Commission is a regulator. The Joint Commission is still called JCAHO. When I'm out speaking or talking to people, they'll say, oh, you guys are the government. No, we're not the government. We just exist to create busy work, paperwork. It's all just policies and procedures. You guys just look at the paper, right? Or we just do surveys. We just go into organizations and survey them. That's all we do. And we're only in hospitals. These are the top myths of the Joint Commission, I would say. You might have some others. What we really are is we're a nonprofit, 401c3, and our name changed in 2007. It's called the Joint Commission, not JCAHO anymore. And we work with the government, but we are not the government. We are not a regulator. And the Joint Commission sets the framework for quality and safety, right? And we do surveys, but we do a lot of other things that are part of that, that I think is sometimes behind the curtain. And it's developing those standards, evidence-based, through many stakeholders. Experts across the country actually participate in that work, in the development of measures, in performance improvement, education, training, world-renowned health services research. And we're actually in all healthcare settings, not just hospitals, home care, ambulatory, long-term care. That's the Joint Commission. This just came out this month. This is the Patient Safety Systems chapter for the hospital program. So you saw that document. I had the minimum standards, a pager, 5 standards from 1917. Well, there are hundreds of standards now. I mean, hundreds. It is a thick book. Well, it's no longer a book. It's online, actually. But let's face it, healthcare organizations are very complex organizations. And so there are a lot of standards. What we did at the Joint Commission was actually take the standards most directly, most important that are related to patient safety around organizational leadership, a culture of safety, and data-driven improvement. Pulled those from the rest of the manual, wrote a very wonderful beginning around patient safety, bringing in those standards, and that's now the first chapter, the beginning of the book, because that's what we're about, is patient safety. This is available to the public, this chapter. You can Google it, just what I have there, and you'll find it. It comes right up. So it's actually great, and I hope we can pass it out to more CEOs and places across the country that don't see or understand patient safety yet. This is a great place to start. So the Patient Safety Systems chapter. It's about patient safety, but it's really, as I alluded to before, it's actually, patient safety is all about reliability. I'm going to spend a fair amount of time talking about reliability today. So one of our colleagues at the Institute for Healthcare Improvement, I think, said it really well. Reliability is failure-free operation over time from the viewpoint of the patient. Many people sometimes equate reliability with safety, just safety alone. Patients don't see it as just safety. Certainly, first and foremost, safety. First, do no harm, don't hurt me. Most don't even think that's possible. They don't know about what we're all here for at this summit, right? First, keep me safe. Do no harm, but also I want effective, efficient, equitable, timely, and most importantly, patient-centered care that aligns with my values as a patient, my goals as a patient, right? That's reliable health care. So if we start with that definition of reliability in health care, it boils down to 3 very important things. The framework that was written about in Health Affairs in 2011 and then more extensively in the Milbank Quarterly in September of 2013, it boils down to a leadership commitment to zero harm. And you might say, but we all go to work each day committed to not doing harm. I'm talking about something different. I'm talking about leadership behavioral changes. Leadership behaves differently when safety is the only core value, when it is the thing that drives the organization. And I'm going to get into some tactics a little bit later where leadership is changing the way they do business. Leadership commitment to zero harm can drive an effective culture of safety, which is a big stumbling block for us right now in healthcare. This is where we need to work. And leadership commitment, leadership really drives that culture. With those in place, robust process improvement, a data-driven, systematic way to driving improvement can happen. And we need robust process improvement. We can't take moderate improvement over years right now. We don't have time for that, right? We can't do projects that aren't sustainable and that don't spread. We don't have time for that. The urgency is here now. So I'm going to focus on leadership for a second. Every single one of you, each of us in this room is a leader. I don't care what your title, what your role is. Everyone is a leader in their own day. Each one of us has an expertise, a knowledge base, skills, a smile that you bring to the table. What is your expertise as a leader each and every day, each and every hour that you can assert? That's what being a leader is. It requires change, and Dilbert probably said it best. I'll watch you and then I'll try it, right? Change is hard. It's hard to be on the leading edge. And many in this room are change agents, but to keep doing it, to keep moving forward and transform is not easy. To think of new ways, not get frustrated, not blame others for not being able to move the ball forward. I get frustrated, I know. I, want to say, oh, I can't do this because of that, I've tried, but a leader continues to exert their expertise and find ways to partner with others and keep the ball rolling. It's about managing change versus leading change. I know oftentimes in my day, and I'm guessing you do too, it's about managing change, reacting. New regulation, new requirement, I have this new assignment from my boss. I mean, it's just keeping the balls juggled, right? Reacting, just managing what's going on in your day. Leaders don't approach it that way. Leaders lead change. No matter what is thrown onto their court, they are leading. They are driving the change. It's a different approach, it's a different mindset. We know there's a long, long ways to go. You've heard all the stats. Everybody here today knows the hundreds of thousands of people that are dying and are harmed in this country. There's 600 fires in ORs, 40 each year, 40 to 50 wrong site surgeries each week in this country, best estimates. How do these other industries do it? These are complex, risky industries, not as complex as healthcare, and they go for long periods of time without harm. Commercial aviation, nuclear power, even amusement parks and zoos. How do they do it? And you would say healthcare is different. It is. It is. It's one patient at a time. We're not machines. We're much more complex. We're individuals. The workforce mobility is huge. Matthew Bell talked about that earlier. The turnover in some of those entry-level positions. It's huge. And we don't even agree on what harm is. We know when something really bad happens, and we know when great care is had, but then there's situations where a patient thinks that there has been a complication, but the surgeon didn't dictate it as a complication. There's two different mindsets there about what harm is. I'm going to start with 5 principles of high reliability organizations. How many of you have heard of high reliability organizations? Most, okay. So the term was coined in the late 1980s by researchers at the University of California, Berkeley. They were studying some of those industries to try to understand how they did it, how they managed this complexity, this risk. Oftentimes with people, not highly educated, but with good training. And this actually, managing the unexpected, builds on that work by those researchers and is by Carl Weick and Kathleen Sutcliffe. I highly recommend it. Very good book. It goes over the principles. And for those of you that don't have a lot of time to do reading, I'll give you the Cliff Notes. It's about anticipating trouble and then understanding that trouble will probably happen. Errors will probably occur because we're human, but to be able to contain them. And that's what these industries do really well. How do they stay out of trouble? Well, they're preoccupied with failure. What does that translate to in healthcare? It means that when a nurse is hanging a medication for the zillionth time in her career, the thought still crosses her mind, what could go wrong here? What doesn't seem right? That preoccupation with failure. A sensitivity to operations, management understanding it, things are different on different units, different departments. And a reluctance to simplify, that when you're in the operating room and the machine starts giving a message that you haven't seen before, that you don't assume that the machine is just broken. That maybe there's more to this. Maybe there's something going on with the patient here too. Maybe we need to stop and take a moment. It's a reluctance to simplify. And then knowing that there are a lot of humans involved in all of these endeavors, and you can't predict every way that harm is going to happen, how errors will go through the Swiss cheese. How do we contain things when they do start to happen, when things start to go south? Well, these organizations have a commitment to resilience and a deference to expertise. It means that in the cardiac OR, the cardiac surgeon is not always the expert. It depends on the question at hand. It might be the perfusionist. It might be the housekeeper. It depends. Defer to the expert depending on the situation. And again, back to everybody is an expert in their day. They bring something to the table, and another person doesn't understand their role, all the things they do in their day, right? That's that deference to expertise. Right now at the Center for Transforming Healthcare at the Joint Commission, we're partnered with the South Carolina Hospital Association and 26 acute care facilities across the state. Their leaders have committed to zero harm, committed to learning and understanding what is done in other industries and what those very select few healthcare organizations have done across the country, and to try to change the way they do business. So that's a work in progress right now. I hope to report more back to you now, but these leaders have signed up for that. We meet regularly, and they share with what they're learning and how they're incorporating things in their organizations. Leaders drive a culture of safety. Could you go back one? Thanks. Culture kind of has the definition, precision of a cloud, I would say, right? There's 100 definitions, people have written all sorts of books about it, but what is culture? And how do you change it? What can really be done? So I'm going to go over a couple of tools, things that leading organizations are doing right now, and I would argue most, if not all, organizations probably should be doing. So the question is your organization doing this? If you're not part of an organization, you and your family are probably receiving care potentially at an organization. Are they doing it? Good question. So let's see. First one is a daily check-in. This goes by some different names. Some call them patient safety huddles. Some call them daily operational briefs. The way that they're envisioned and done in some organizations right now is in the morning, typically around 8:30, a leadership team, C-suite, and the departmental unit heads, radiology, neurosurgery, pharmacy, all get together. 15 minutes, that's it. Sometimes they do it in person, it depends on the organization. Some do it by phone. And they go around the room in the same order every day. And each department head looks back and they report on any significant safety or quality issues from the prior 24 hours. They look ahead to any anticipated issues in their area based on what they've seen as they walked in, at 7:30 or whatever in the morning, what's going on in my unit, and any follow-up. Based on what I just said, there's been some issues identified or follow-up from the day before. 15 minutes. And it drives culture change. That is what we hear. Because the focus is on safety. The department heads see the CEO there. CEO isn't always running the meeting. Sometimes the CEO feels more comfortable with a chief medical officer, that type of person running it. Some organizations rotate the person running the meeting. But it's quick, in and out, and it's all about safety, 7 days a week. Another thing is a safety moment. A safety moment is a brief safety talk about a specific safety-related topic or a patient's story at the beginning of a meeting or a shift. This is tangible. This drives culture change. A CEO, a department head starting a meeting like this every time, their whole team knows that, oh, safety must be important. Safety comes before productivity. It's these types of behaviors that drive culture change. Other industries have figured it out. When these big accidents happen, you can go back. The culture is at the heart of it. Metro North, BP oil spill. Culture is predictive, and it sort of makes sense. But in healthcare, we need to have data and prove it and put it in all the journals. So the body of evidence is growing. Organizations that have better culture have less medication errors. Organizations that have better culture have better patient satisfaction, better nurse satisfaction, less nurse turnover, all the things that we're trying to work on. Culture is a leading indicator. Today, unfortunately, we react after adverse events. It fills up all of our time trying to understand what happened so we can prevent it. In those industries, they're really focused on proactive assessment of safety systems. Upstream, the unsafe conditions. We don't even know what those are right now in healthcare. I mean, we're so focused on just reacting because we don't have time, right? But this is where we want to go. And culture change, it is difficult. The Agency for Healthcare Research Quality has a safety culture survey in many settings at this point, but right now in the hospital setting, there's a few questions I pulled out right here about culture. So staff feel mistakes are held against them. When an event is reported, it feels like the person is being written up, not the problem, and staff worry mistakes are kept in their personnel files. That's fear. Fear is the worst thing for a culture, right? Well, what would you think the percentage was in 2007 of respondents that felt this way? What do you think? 50. Oh, you're good. You must have known the answer. 50% or more of people did. And by 2012, no change. Totally scary with all this work and focus on safety and quality. And some of you smarty pants in the audience I know might say, well, it's a different sample. If you took the same sample, which I have another slide, but it says the same thing. Literally, the numbers are identical with the same sample. Intimidating behaviors are at the heart of a lot of our difficulty with culture in healthcare. We are still craftsmen. We still do what we want, you know? And intimidating behaviors, this hierarchy across disciplines and within disciplines exists. The Joint Commission came out with a Sentinel Event Alert in 2008 that said behaviors that undermine a culture of safety. Intimidating behaviors contribute to poor patient satisfaction, adverse outcomes, errors, increased cost of care, and increased turnover. All the bad stuff. Well, we know that physical abuse and verbal abuse are bad and we should get rid of. But what actually comes through in this, and the Institute for Safe Medication practices, the data actually talk about condescending tone and impatience with questions. It's that stuff that's under the radar that happens every day that make people not want to speak up, not want to call that prescriber again to clarify the order, that they try to figure it out themselves. They don't speak up. This is at the heart of a lot of what we're dealing with in healthcare and moving the ball forward with respect to safety right now, are those types of behaviors. This is a small tool. This is not going to solve the intimidating behavior thing. But what I wish there was more of was cussing in healthcare, where frontline staff felt more comfortable saying, I'm concerned, I'm uncomfortable, and this is for safety. Organizations that have done team training, team steps, this is one of the things that's taught. This is one of the tools that is taught to frontline staff to use with each other. It's a little bit safer. So hopefully we're going to hear some more cussing. But again, I don't mean to make light of intimidating behavior. This will not solve that, but it is a tool. It's a lot about putting more effective accountability systems into healthcare. We don't have them. When there's a bad event, the nurse gets fired, and the doctor maybe gets a note in the file or not, right? There's a difference in the way disciplines are treated between departments across disciplines. There's different expectations, there's lack of clarity. How do we decide what is blameless and what is blameworthy? Most of the time, things are blameless, but to have a completely blameless culture, it's a free-for-all. There has to be some accountability and expectations, clarity around that from management, and we lack those systems in healthcare. This was developed in the United Kingdom. It's the culpability algorithm tree, essentially, developed by James Reason, and it basically boils down to these 4 questions. Did this person intend to do harm? Well, most of the time, no. I mean, but there are rare instances of criminal activity, so you do have to first and foremost ask that question when trying to understand an event. The next question is, was there evidence that this person had mental illness, substance abuse. Again, most of the time, not the issue, but occasionally it is, and that, there are certain ways and support systems and that type of thing to address those issues. The next question is around the foresight test. Were there workable, intelligible policies, procedures, protocols for this situation in place? Did this care provider actively try to do reckless behavior? Were they trying to be reckless? Did they go around it knowingly? Or were the policies not so clear? Were they buried in a dusty binder under the nurse's station? And the physicians hadn't really been educated on that policy. Was it management's responsibility? Or were those policies and procedures clear and everybody's aware and everybody did it this way, but this practitioner decided to, sail a different direction? If you go through the foresight test, the next one then is the substitution test. Would a practitioner of similar background and experience have done the same thing, acted the same way in that situation? Other people, say, on that unit with the same training and education. And that's how you can start to understand the contributions of the individual and the systems. It's a guide. There aren't answers. But the more that an organization comes together and has consensus on the answers to these questions across departments and across discipline, it brings trust to frontline workers, trust in management, trust that things are fair across the organization. So, as soon as we solve all the culture stuff, at the same time, robust process improvement is what will help get us to reliability and zero harm. Robust process improvement really takes management systems. It's not just the tools, the process improvement tools that we all know from manufacturing, but these approaches are management systems. Lean removes waste, and many organizations in healthcare right now, are going through lean transformation and say, all we need is lean. I would argue something different. I would say we certainly need lean. We need to remove waste in healthcare. I'm the first one to say that. But we also need to reduce variation, and there are a lot of tools from Six Sigma that we need to bring standardization to some of those care processes. We also need facilitating change management, tools that bring accountability and acceptance. Otherwise, solutions fail. When you do a change initiative, 40–50% of the time, those things fail because there isn't the acceptance, the local acceptance and accountability around those solutions. And you go back a year later and the change you put in place is gone. Nothing's really changed. So facilitating change tools are very important. So this conglomeration approach is robust process improvement. We need it all in healthcare, let's face it, right? We need to put everything we can. The important thing is the explicit leadership commitment and the focus on the patient. Everything starts with the patient in these approaches. Facilitating change. Ernest Amory Codman could have used more of these tools and maybe his ideas would have been accepted a little bit earlier. But effective leaders plan and use certain tools in their planning. They know how to inspire people. People need to be inspired to change because change is hard. So every single one of us, how can we inspire those around us in our day? And then being able to formally launch, to communicate, have that communication plan on all levels, and to support the change as a leader. We know that this approach leads to major improvements. Hand hygiene is one of the key drivers for healthcare-associated infections. A meta-analysis of 96 studies showed that healthcare workers wash their hands an average of 40% of the time. 40% of the time. We don't wash our hands reliably. If hand washing is improved from just 40% to 65%, healthcare-associated infections will decrease by 37%. We at the Center for Transforming Healthcare, we partner with leading organizations across the country that use robust process improvement. They partnered together and improved hand hygiene by 71%. They tackled handoff communication failures. Why? because handoff communication contributes to the vast majority of adverse events in healthcare. They didn't just measure a sheet of paper to see if the sheet of paper had been filled out. They measured how effective the handoff communication actually was. That's what this approach does. They were actually able to measure the risk of wrong site surgery. And what are they measuring? They're actually measuring behaviors of the team in the OR. It's a different way of looking at it. You know, when you ask organizations, what is your risk of wrong site surgery? And they kind of scratch their heads and go, well, I think we had one 4 years ago. We're trying not to have another one, you know? No, you can measure the risk and decrease it. The hand hygiene work was just published actually this month in the Joint Commission Journal for Quality and Patient Safety, and there's some copies around that I brought if you're interested, and it's all about reliability. It's about that initial project, but then it's about spread. It's about the spread work to other organizations, hundreds of hand hygiene projects, and the improvement in compliance. It's all about reliability. We have done a fair amount of work in the area of preventing falls with injury. There are approximately 11,000 fatal falls each year in hospitals. 5 hospitals partnering with the Center for Transforming Healthcare reduced their falls with injury rate by 62%, and the injury rate from 33% to 19%. If other organizations were to take this approach, even a small hospital would have 72 fewer injuries and avoid $1 million in cost. A small hospital, medium-sized to some. So that work that's been done in the center with these leading organizations that have skills in robust process improvement has been translated into an online application that's available to any accredited organization called the Targeted Solutions Tool. It's totally separate from accreditation. There is a firewall. We legally cannot share it with accreditation. For organizations just to use to improve. It guides them through a robust process improvement project, a robust hand hygiene approach. It guides them through handoff communication and how to fix it, where you measure the current state, analyze the key drivers, select targeted solutions, and implement a plan for sustainability and spread. We are developing the Preventing Falls with Injury module as we speak. It'll be available later this year. So it guides organizations through. It's very easy to access. It's right on the Center for Transforming Healthcare website. And if you're at an accredited organization and your email domain is of that organization, just click there and it's a quick turnaround. That's really for any project lead. It's an online application for a project lead. I'm also going to talk about another tool that can assist leadership in looking at their organization. It's a look in the mirror. It's called the High Reliability Self-Assessment. And it actually is a questionnaire for a leadership team to take a look in the mirror. How are we doing with our board and board engagement around zero harm? How are we doing with transparency of our quality measures? How are we doing with trust and accountability? What are our methods for process improvement and performance management? It's a questionnaire that the whole senior team comes together and walks through. The South Carolina folks, they've all done this. And the thing that they say is, wow, we needed to have this conversation. It was very helpful to us because we see these are the important things we should be doing that should be tied to our strategic planning. So this tool, this questionnaire, along with tools and resources to help organizations take the next steps, will be available later this year. High reliability is achievable. We are seeing it in select organizations across the country. Zeros. Organizations that go for an entire month with 0 healthcare-associated infections across 9 different types. 0 is possible. But it's not a project. It's more than a project. It's a change in behavior. It's a commitment to a goal of 0, a fully functioning culture of safety, and highly effective improvement capacity. And I guarantee you it is not just going to help with safety. It helps with everything else. Efficiency, bottom line, effectiveness, everything. So hopefully your heads are swirling with ideas and things that you want to do when you go back to your organization from all the great things we heard this morning, from hopefully some of the things you heard here. We have great ideas, but let's face it, it's all about action. And I believe collaboration, meetings like this, help drive us towards action. So we want to collaborate with all of you. That's why we're here. We do collaborate with the government, the Centers for Disease Control, healthcare organizations, patients, industry, clinicians, and many others. I love being there because we get to work with everybody in this room and so many others across the country to make healthcare better for every single patient. Many people will say, well, we're doing this because the Joint Commission says we have to, and it's a waste of time. It's just busy work, verbal orders, authenticating within 48 hours. We have to have a director of outpatient services, even though it doesn't make any sense with the way our organization is structured. You know, certain things don't make sense in 2015, but these were on the CMS conditions of participation. They weren't necessarily our standards. They really were CMS. So one of the ways that we've collaborated with CMS to help organizations to get rid of some of the waste and useless things that you have to do, we got rid of them. We worked with CMS and said, organizations do not need this. We are in the field, we're in hospitals, these do not contribute to quality and safety right now. And CMS said, okay. I mean, it wasn't that easy, I guarantee you, but we did get there. You know, so that's the kind of thing that's one teensy example of many, many things that we do. You know, that's on a big, larger scale, but on smaller and different scales too, we work too. Right now, we have some opportunities for healthcare organizations to partner with us at the Center for Transforming Healthcare. So I invite any of you to contact me at any point, DuPree@jointcommission.org. And right now, we're recruiting organizations to partner with us on the tool development for preventing falls. And that will be kicking off pretty soon, so you need to contact me like this week. And when the tool actually goes live later this year, we will be starting additional collaboratives to help the networking and sharing of walking through the tool through the guided projects. And in addition, we're working with and talking to state associations, large health systems about high reliability. How can we get our region, our system to understand these concepts, to start thinking about them? And so we'll be partnering with those types of organizations going forward the way we are in South Carolina right now with the development of the high reliability self-assessment tool. So this is just a few options. There are many others too, but I wanted to highlight these and offer them to anyone that would like to partner and continue the commitment to zero harm. So we've learned that accreditation is about excellence in patient care. Patient safety is really about reliability. And I know every single person here is ready to turn all of these ideas, these great things we're hearing about from everybody and all the panels and things today into action. Just like Ernest Avery Codman, right? He turned ideas into action. He was a revolutionary. He blazed the trail for many of us, right, in this room. We owe a debt of gratitude for his commitment. And I am so happy all of you are here today at this summit. Thank you, Joe, for this wonderful gathering to have all of us here. And I leave you with this thought. What is your call to action? And I think most of us in the room have some call to action around patient safety. That's why we're here today. But calls to action happen at different times, and there isn't just one. Right? They happen over and over again in different ways. One of my early calls to action around this work was as a practitioner, as an OBGYN. And I was taking care of a patient, healthy young woman, physician, and she went into labor one night, and my partner was on call. And he watched her labor. He didn't have to manage anything. It was a perfect labor. And she got to fully dilated, and the heart rate bottomed out. Flatlined. He called for forceps. My partner did. Very skilled practitioner with forceps. And so the nurses ran down the hallway to the supply closet to get the forceps and brought him back. And he opened them, and they were the wrong type. There's different types. And he said, I can't use these in this situation. I need, and they were labeled wrong. Nurses ran back. They had to open, I don't even remember what it was, 5, 6 of them to find the right ones because they were labeled incorrectly. Precious minutes dictated the outcome, which was very poor. Nobody's fault. But who was how did it happen that we didn't have the systems in place to properly label? That if somebody didn't know, they didn't feel safe to speak up and say, actually, I don't know what type of forceps this is or how to label it. Clearly that wasn't present, right? That changed certainly that family's life, right? And it was those types of experiences, certainly as a practitioner, that were part of what called me to this work. And I continue to hear stories and live stories, with friends and family about why we're all here. So it helps because sometimes it's easy to get down or frustrated, right, with the things that aren't moving your way in this work, in this movement. And so I ask you, what is your call to action to transformation? So thank you.